Thank you, Dr. Raja. Thank you, Dr. Bhattacharya, for having me as a part of this important symposium and tasking me to talk on respiratory viral infection preparedness for the new epidemics. This is a snapshot of the various emerging and re-emerging infectious diseases, as you can see, of the various re-emerging and emerging infectious diseases. We see a number of viral infections that are contributory to the to these, and most of it is contributed by viral infections like influenza, Ebola, Zika, etc. And these are recent landmarks events in even emerging infectious diseases from 1981 when HIV was reported till 2019. A number of respiratory viral infections have contributed to these epidemics, and these have included the various influenza pandemics, as also the Ebola, the Nipah viral epidemic, and now the COVID-19 that we are still grappling with. So I've been specifically asked by the organizers to not be speaking about COVID that we have been hearing about for the past 1 year. So I'll be restricting myself to other respiratory viral infections, especially influenza. And this is a snapshot of what has happened since 1900s in terms of and the influenza pandemics and emerging new pandemic threats because of influenza virus. And we can see that the worst has been the 1918 Spanish flu, which consumed around 50 to 100 lives, and the last was the 2009 H1N1 pandemic. The circulation of the influenza viruses in poultry and their high fatality rates have raised concerns over these pandemics actually spreading over to the humans and causing sustained human-to-human transmission, which can actually result in pandemics. And if we go into the comments of the Director General of the World Health Organization, says that the threat of pandemic influenza is ever present. The ongoing risk of a new influenza virus transmitting from animals to humans and potentially causing a pandemic is real. The question is not if we will have another pandemic, the question is when. We must be vigilant, prepared, and the cost of a major influenza outbreak will far outweigh the price of prevention. So influenza prevention and control and preparedness has been a major focus area for the World Health Organization since 2002, and various achievements in this regard have included an enhanced global surveillance and response system, what we call as the GISR system, which has resulted in improved epidemiological surveillance and monitoring and better detection methods. Influenza pandemic preparedness framework has been developed. Some international regulations have been put in place, which have been implemented. Then a SAGE group has come, which is a strategic advisory group of experts on immunization recommendations that recommend various vaccination strategies for the policy planners. And global action plan for influenza vaccines is in place. Public health research agenda for influenza has been developed. Then there is an improved One Health collaboration and WHO Health Emergencies Program. However, there are ongoing challenges in the influenza prevention, control, and preparedness strategies, and they vary from epidemiological and virological surveillance to antiviral drugs and other treatments for clinical management. I'll be specifically focusing on the scenario in India. And if we talk of in India, there has been a limited data about influenza prior to 2004, which was mostly concentrated about study of various epidemics. Till in 2004, there was a collaborative agreement signed between the Indian Council of Medical Research and the CDC of the USA, wherein they looked for strain surveillance with and a network of laboratories was set up across the country in various geographies, and a referral center was at Pune. And based on this, strain surveillance was started. And this is a throwback picture of the pandemic, 1918 pandemic. And if we can see that the one single country that was most affected in terms of total mortality was India, with more than 15 million people perishing over a short span of 1 year, and India registering a negative growth in population, this being the only time. And this was what they found on the basis of their multi-site virological influenza surveillance, that of the 14,000 samples that they collected, around 4.3% were positive for influenza, constituted by H3, H1, and type 2, type B influenza viruses. Subsequently, they found that the patterns of influenza circulation were different in different parts of the country, with some having a northern hemispherical pattern of circulation, whereas some are having a circulation which mirrored that of a southern hemispherical pattern of circulation. We demonstrated that influenza was responsible for causing acute respiratory illnesses, was responsible for causing various epidemics, and we had a resurgence of influenza, and then we had a genetic variant that came up in 2015. We also demonstrated that there were stark differences in patterns of influenza circulation in India, and for influenza circulation, India behaved more like that of a continent rather than a single country. Though it is geographically India is supposed to be in the northern hemisphere and have a northern hemispherical pattern of circulation, we found that the patterns of circulation were different. For example, in two cities that are just 500 miles apart, that is Srinagar and Delhi. Srinagar exhibited a northern hemispherical pattern of circulation, whereas Delhi exhibited a southern hemispherical pattern of circulation. So we came up with a proposal that influenza circulation is not the influenza equator is located somewhere at the 30-degree latitude. Anything north of this latitude actually depicts a northern hemispherical pattern of circulation, and anything south of this influenza equator, which constitutes most of the Indian geography, is exhibits a southern hemispherical pattern of circulation. This was published, and then this has a huge impact in terms of the vaccination timings for various regions of the country. And surveillance is extremely important in order to understand what is the pattern of circulation. As you can see, this current year, when COVID was running in parallel, influenza circulation has been hardly any in southern hemisphere, as exhibited here by Australian circulation. You can see that there's practically no flu in Australia, Chile, or in South Africa. Next challenge is having an idea about the disease and economic burden. Unfortunately, there is scant data about it available in the lower and lower middle income countries. We know from our coordinated collaborative study between the Institute of Health Metrics and Evaluation, the Public Health Foundation of India, and the Indian Council of Medical Research, that lower respiratory tract infection and chronic obstructive lung disease constitute 2 of the 5 most important causes of premature death in India. And on the basis of a global burden of disease studies, we found that burden of chronic respiratory diseases in India is huge, and there is a number of global, regional, and national morbidity and mortality is caused by lower respiratory tract infection. A significant number of them is caused by influenza. We demonstrated that influenza is responsible as a pathogen in a significant number of patients with community-acquired pneumonia who are hospitalized. It also contributes significantly to the patients of acute exacerbation of chronic obstructive lung disease, with 8% of the AECOPD being attributable to influenza. It also causes significant illness in pregnant females, with adverse consequences of death and intrauterine death of the fetus. And then influenza also is seen in patients who come back from religious pilgrimages, and in this instance we demonstrated that influenza was very common in patients who came back from Hajj and Umrah. The similar kind of studies have not been done in other religious pilgrim congregations like Kumbh Mela, where we need to find out whether there is an increased influenza circulation. This has also effects on the economy, and this is probably the only study that we did in a public health facility as well as a private facility, where we looked at the cost of acute respiratory infections in northern India, and we found that depending on the setting, be it a public facility or a private facility, the cost of influenza acute viral infection ranged from $4 to $6 to as high as $355 for hospitalization in a private facility. Next, we come to pandemic preparedness. We have various phases that happen in a pandemic, where we have various phases of increasing circulation. With phase one, where there is no animal influenza virus circulating among animals, having caused infection. Then we have cases that have been reported in humans, and then subsequently there are sporadic or small clusters, then human to human transmission, then a sustained community transmission in at least two countries in the WHO region. And then in phase 6 there are sustained community level outbreaks in at least phase 5 countries, and another country in another WHO region. Then there's a post-peak period, a possible new wave, and the post-pandemic period. The main actions of in the influenza action plan include producing, implementing, exercising, and harmonizing the national pandemic influenza preparedness. Then, in once the actual pandemic is there, we need to take measures of rapid containment, then readiness for a pandemic response, and then each country has to implement actions as called for their for as per their own national plans. And then in the post-peak period, we have to evaluate the response, recovery, and prepare for a possible second wave. And once there is a possible new wave, then we have to have a similar kind of a response as we had for the first wave. And then in the post-pandemic period, we have to evaluate the response, the revision of the plans, and recovery. Non-pharmaceutical interventions have never been a focus as much as we in the recent pandemic of COVID, and we must exercise the COVID appropriate behavior. What has been truly emphasized in terms of mask usage, the single mask, double mask, or whatever is the regulators' advice. Then social distancing and hand hygiene. Next, we come to vaccines and vaccination programs, and we know that for influenza, one single intervention that's most important in preventing and development of infection, developing a hospitalization because of influenza, and reducing mortality and transmission is influenza vaccination. So, influenza vaccination reduces the likelihood of developing influenza, reduces the severity of disease among those who develop influenza, and reduces the likelihood of transmission. Unfortunately, regardless of the age, the influenza vaccination uptake, this is the data from CDC, and has not been optimal. And in India, influenza immunization is not included in the national immunization program or the universal immunization program, and it has been only recommended by the Minister of Health and Family Welfare for healthcare workers and pregnant females and high risk cases, but is not supported by the program. We have developed some recommendations. These are the South Asian recommendations for patients for vaccination against adults in high risk groups. Then there have been a number of documents published by various physician bodies, be the Indian Academy of Pediatrics, the Geriatric Society of India, or the FOGSI, that is the Federation of Obstetricians and Gynecologists of India. And then we have had a recent document by the Indian Chest Society and NCCP, which came in last year, emphasizing influenza vaccination in high risk individuals. However, despite these recommendations, unfortunately, we have documented that be it the chronic obstructive lung disease, be it the diabetics, be it the patients with heart failure, or be it the pregnant females, the influenza uptake is abysmally low, and being the highest probably in diabetics with 9% uptake. If you look at who influences the adults' decisions to get immunized, around 90% of the decisions are basically helped by a personal physician, up to 70%, and probably vaccination of a fellow family member, that's around 19%. And looking at the attitudes of healthcare providers, we wanted to find out what's the knowledge, attitude, and practices about the seasonal influenza vaccination among healthcare workers in Srinagar, in India. We found that despite the fact that 1400 plus healthcare workers knew that influenza is a potentially serious illness with potentially serious consequences, only 4.4 of them percent of them were actually vaccinated, and they give a variety of reasons. They did not find that they had a belief in the efficacy and the safety of the vaccine, and they had a lot of misperceptions and misconceptions, and they did say that university universal immunization programs do not recommend vaccination. Cost, they said that it might be an impediment, and influenza vaccination in different geographies has got to be timed differently, and there's an inadequate and patchy surveillance. However, and so as a result, there was a lot of hesitancy, and then there are anti-vaxxers who always talk against the vaccine. And the biggest barrier, however, is the poor sensitization of the poor care providers. If the doctors do not themselves take the vaccine, do not prescribe the vaccine, obviously the patients are not going to take it. And it's also extremely important that we know that there could be a close circulation of the viruses, and it is imperative that we stay protected against one of the viruses against which a clearly effective vaccine is available. And we must get data in order to find out whether the influenza vaccine is effective. For example, in this case, this probably being the only influenza effectiveness study, vaccine effectiveness study from the country, and where we demonstrated that influenza vaccine was not hugely effective, but was effective in reducing the hospitalization by 16.3%. So, and then once we are talking about antiviral drugs and other treatment protocols for clinical management, there should be antiviral agents available, and treatment modalities have got to be there for appropriate clinical management. WHO has come up with a global influenza strategy to prevent, control, and prepare influenza from the period from 2019 to 2030, having certain strategic objectives with high-level outcomes, with the eventual goal of reducing seasonal influenza burden, reducing the zoonotic influenza risk, and minimizing the pandemic influenza potential in contribution to the accomplishment of the sustainable development goals. And the high-level outcomes are that we need to have better global tools, a focused, consensus-driven plan that leads to greater research, innovation, and availability of new and improved tools for the prevention, detection, control, and treatment of influenza. There has got to be a stronger country capacity, and every country has to have a prioritized influenza program that is evidence-based, is optimized to fit the country's needs, and contributes to national and global preparedness response and health security. So in the first strategic objective, we have to promote research and innovation to address unmet public health needs. We must promote research and innovation for improvement in improved and novel diagnostics, novel vaccines and treatments against influenza, promote operational research for influenza prevention, control, and program delivery, promote research to better understand virus characteristics and host factors that drive the impact of influenza. We have to strengthen the global influenza surveillance, monitoring, and data utilization, wherein we must enhance, integrate, and expand the virological and disease surveillance, build a strong evidence base for understanding the impact and burden of influenza, and develop effective communication strategies across multiple sectors and between stakeholders. There has got to be an expanded seasonal influenza prevention and control policies and programs to protect the vulnerable. So we must integrate the non-pharmaceutical interventions in the prevention and control programs, design and implement various evidence-based policies and programs to reduce transmission and disease severity, design and implement evidence-based treatment policies and programs to reduce morbidity and mortality. And then we must strengthen national, regional, and global planning to enable timely and effective pandemic readiness. So the optimal preparedness must be multifactorial, ranging from biomedical research to robust communications to securing funding, lab capacity, surveillance, health care infrastructure, trained health workforce, and community engagement. A word about vaccine platforms. We have a number of platforms available, from genetic immunizations to viral vectors to recombinant proteins to nanoparticles and the virus-like particles, and the various vaccines that have been targeted by these platforms have been reported here. COVID vaccine has actually taken help from nearly all of these platforms. So what is important is that we must develop enough evidence base for recommending the vaccines. So I take you in final 1 or 2 slides to this editorial that we scripted together, Dr. Rajadharan. We said that we were taken off guard once we were confronted with COVID. So for a country of 1.3 billion people, a spending of 1.2% of GDP on healthcare may not be just enough to ramp up our capacity. And the policy planners need to take a serious call on recalibrating our priorities, because once it comes to the choice of life versus livelihood, the former takes a precedence. We need to better prepared whenever the next pandemic hits the world, so that we are not again caught off guard. And public health spending actually determines your possibility of having an outbreak that transcends your borders and leads to pandemics. So concluding, ladies and gentlemen, we need to be prepared, and we need to learn our lessons from the COVID pandemic. The infodemic of fails and wrong information needs to be fought. Untried, unproven therapies should not be advocated, and that we have seen in pandemic. We must avoid jumping to conclusions. Basic science has got to be blended with clinical medicine. Vaccines should be promoted on science, not on political will. Coordinated response is the key, and policy planners and the executors have to work in tandem. Regulators need to back their recommendations, but by robust scientific evidence, and we need to do better for preparing ourselves in terms of encountering a new pandemic, and healthcare spending has got to be ramped up appropriately. Thank you for your kind attention.